The best way to introduce my guest is to read you this. We congratulate Professor Eliane Cribier for receiving by presidential decree the rank of Chevalier in the French Légion d'honneur, acknowledging his distinguished contributions to the service of medicine through the design, development, and first implementation of TAVR in patients with severe aortic stenosis who were non-operable or had high-risk surgical risk. 10 years of TAVR. Congratulations.
Thank you very much.
After 10 years, what do you think? Has it been fun? Is it better than you thought?
I am not sure that the word of fun is really adapted, but it was really. I am absolutely stunned by the expansion 10 years later of this new technology, because I have been under the criticism of so many experts at the beginning of this experience. And 10 years later, not only TAVR does exist, but also it's keeping expanding worldwide. So there are not so many interventional cardiology procedures that did survive 10 years and keep expanding after 10 years. I can just compare with coronary stent, for example. So I am really fascinated because today, after all this very difficult period of development, we have more than 50,000 patients benefiting of this new technology worldwide. So I think we can say that it's a big success.
There has been tremendous care and dedication among those people who are expanding this over the course of the 10 years. It seems to be a more thoughtful rollout of a technology and device that I have ever seen.
Yes, well, actually, I am also stunned by this the unbelievable progress in technology that explains also partially the expansion of the technique. First of all, there is a clinical need, so we could expect to have this expansion. But the improvement in the technique have been so huge, I would say mainly since the last 5 years, with better devices, an improvement in the approaches, a decrease in size of the devices, and more or less a better understanding of the screening of the patients. If you put all of that together, we can understand that now today this technique is really so largely used worldwide.
So in 5 years from now, 10 years from now, what do you expect to see?
Well, within 5 years, I cannot really read in the palm of the hand, but we can probably foresee an expansion of the indications to patients who are at lower risk or younger patients. So this is the current expansion that we can observe in Europe. As you know, the prognostic score for including the patients are steadily decreasing. So today we have 2 studies which are assessing the effect of TAVR in patients with a relatively low Euroscore or low STS score, like the TAVR trial in Europe and the Partner 2 trial in the United States. So this is a way to move very carefully, if we want to expand the technique to patients who are younger, less risky patients for surgery, keeping in mind, that the surgery, valve replacement, remains today the gold standard. We have to keep in mind always that the results of surgery are excellent, with excellent lasting results after 10 years, 15 years, 20 years. And so this is a tough competition. We have to move very carefully, and we cannot accept to take any risk with the patients by implanting this valve in younger patients, low-risk patients, or just say in all patients. The goal of replacing surgery has never been mine. The goal of this technology is to be applied in patients who are not optimal candidates for surgery. It's absolutely clear. Now, if you ask me the questions about 5 years, within 5 years, definitely we will see an expansion of the technology to less sick patients. Now, within 10 years, probably this technology will be applied in the majority of patients with aortic stenosis, but some very specific indications will remain forever in the hands of the surgeons, like, for example, very severely calcific bicuspid valve, which are more frequent in younger patients.
The very first patient you did, if I remember right, he was like 57 years old, and he had been rejected 3 times by surgeons.
Well, the very, very first patients had all the contraindications that we respect today for doing TAVR. Not only he was 57, he was in cardiogenic shock, he had no myocardial contractility with an ejection fraction of 10%, and also he had a thrombus inside the left ventricle. So all the contraindications were there. And
he'd been rejected 3 times, so
yes,
obviously...
he was rejected not only 3 times, it just could not be operated on. It was a formal contraindication to surgery. So I must say that sometimes we need a little chance. When we start a new procedure, I hesitated a lot. And also because in these patients we didn't have any femoral artery approach feasible because the two femoral arteries were occluded. So we had to improvise a transseptal approach for these very first patients who had all the usual contraindication of TAVI. So God was with us in the cath lab this day.
Thank you very much for 10 years of changing lives. I appreciate it a lot.
Thank you.
Thank you, sir.
Thank you.